I'm going to make everyone exercise because I've done my crunches today. I'm not running around handing the mic to people. So instead, I'll have you come to the mics as you ask your questions. We'll start with Dr. Jerkovich.
Thank you very much for all these sessions. That was really fascinating. And I learned a lot because I don't know anything about all this. And I have a question that follows up a little the question of Dr. Weintraub related to research and the link between incarceration and post-incarceration research. There are very strict policies for by IRB, by all our IRBs related to research, among prisoners, and justifiably so. So how do you handle this? And how? I mean, do you have a central IRB, or do you do research within all? I mean, for all your institutions with each of your IRBs?
So one of the things I think it brings up, your question brings up 2 points for me, is that the easy question is we don't have a centralized IRB. We're working towards a centralized IRB right now. And the reasons why it's incredibly difficult is that IRBs across even our 16-site network have very different definitions and interpretations of the Office of Human Research Protections regulations of what constitutes prisoner research. And so that's one issue, is that I could give you kind of specifics across the network, and this is why we were actually delayed in enrolling all 2,000 instead of 800, is that even for the use of administrative data to study the efficacy of our programs, some sites would interpret that well, you don't know if people that have histories of incarceration would go back in, and that is a reason for us to get Office of Human Research Protections at the national level. Our IRB at Yale didn't think we needed that. We're just following them post-release. And so there's a lot of heterogeneity in the interpretation of those kinds of regulations. That's one. The second is, I think that one of the things we're working on as a network is really trying to think about the regulations as it exists nationally. The Institute of Medicine in 2003 convened a workshop looking at, again, research among kind of individuals with histories of incarceration, incarcerated populations, and actually proposed that for research with minimal risk, when people are in the community, research with administrative data, research that will improve the population. So again, like Cardia, they recruit people, or our study, we recruit people when they are released from prison, they consent in the community, and then you're just following them through the prison system, that there ought to be a lightening of regulations. And still, there's a lot of debate, even among people in our network, of whether or not those regulations ought to be loosened. And so it is, it's not to say it can't be done. We managed to get OHRP approval. That it wasn't a hard task, but it is something that as you move forward in studying, which I think is critical, studying this transition between prison to the community, that there are additional barriers, in particular if you in doing research.
Right. We have another question. Oh, was there another response?
Right, and so the other thing is that on top of OHRP approval, we also got certificate of confidentiality, and that is critical, I think, to doing work with this population. Inevitably, you're asking about, drug use following release from prison, and that's a criminal activity, and so having those kinds of protections are also imperative. Thank you.
We have another question.
Hi, thank you all for your talk. I'm a psychologist here in the system, and to Dr. Redmond's point, the first time I was meeting with an incarcerated person, I realized there was 2 correctional officers there, and a lot of the things that I would typically ask someone as a psychologist, I felt like I had to stop in my tracks and sort of back up. So I kind of implicate myself in this, but oftentimes we hear about the low literacy rates of incarcerated persons in terms of their health literacy, but we don't speak about the low literacy of clinicians, physicians, doctors, other clinical staff in terms of working with folks who've been on the inside, even what terms to use, what health conditions they might be more vulnerable to, that kind of thing. Can you speak a little bit to how you train your clinicians, and specifically, I'm a huge proponent of community health worker models. Are the community health workers sort of in a position to also be training the clinicians as well?
I couldn't agree more. I mean, I think often, we as a health profession should be more inward facing and inward looking and thinking about kind of what competencies we have. And I think that this is a place where we're mostly incompetent. There's, one of our colleagues did a study looking at kind of the residency programs for internal medicine, across the country, and found that only 22 at any point in time talk about kind of correctional health. And so the work that we do in our network is really trying to first just inform healthcare providers that there is a health system behind bars, then thinking about the language of how you address, then getting to more complicated issues of, I was sharing this last night at dinner. When sites start, often there is a natural inclination. It might be kind of, a normal human tendency of curiosity of looking up patients on the internet, and the issues is that then complicates your relationship with the patient, right? It inevitably leads to biases, both explicit and implicit, and so these are kinds of things that can be taught in training programs about how best to care for people that are coming home from prison. The other thing I think is important is that, we have these set-aside programs based within community health centers. Each and every one of us has seen people that have come home from prison. You just may not know it, right? And then each and every one of us have seen people that have committed criminal acts that may not have gone through the prison system. And these are kind of important conversations, albeit difficult to have, but important ones to discuss. And so before kind of clinic programs get started, we often lead the health teams, the front desk staff, the provider, and the community health workers there doing this, of what it's going to feel like, talking about kind of race, racism, our own biases, our own preconceptions, misconceptions about people with histories of incarceration. These aren't easy conversations, but I think they're critical to engage in, whether or not you're starting a transitions clinic program or not.
Have a question?
So first, I just wanted to thank you all for your presentations. And I had a question about chronic disease. So Dr. Redmond, you mentioned that chronic diseases were, more likely in incarcerated persons, and I was wondering if you had studied not only internal, but I guess musculoskeletal issues as well, and if you had any data on the rates of chronic musculoskeletal issues in incarcerated persons versus the general population.
Things like low back pain or something like that. I don't recall right off. I'll have to double check that particular report. I'm happy to share that reference. So I don't know specific to that. But I think also that brings the challenge of, okay, what do you do about it? And a lot of the therapies, like I mentioned, at least within, I think different jurisdictions have different policies in terms of how they deal with simple over-the-counter. So, just grabbing an ibuprofen or a heating pad, isn't as straightforward, at least within the correctional facilities. And then, maybe there's how that is managed, through the transition, I think is met with similar challenges as any other condition. I did want to make a point, and maybe Emily and I can have a little conversation about this, is I think one of the challenges with this population, we might have touched on it in terms of cost and, where the cost savings is that, when people have delayed care, they're actually more expensive initially. And I think that's one of the challenges that kind of expecting that and then preparing your administrators to say, hey, this is going to be an investment, and having a longer range view of when you expect to see return on that investment, because it's probably going to be much more costly initially to kind of play catch up for the extensive delay in care. And I think from a political standpoint, in terms of if you think about public funding and being accountable for how that public spending is happening, your policymakers they have a little shorter time cycle, kind of time with the election cycle, that might not jive with when you're going to see the results in terms of return on investment. So knowing that up front and managing that in terms of your messaging and your agreements and the expectations, I think is something to consider.
We have another question.
So it's a comment followed by a question. So I mentioned before about federally qualified health centers, and thank you first for your presentations today. And it's kind of interesting seeing how you've integrated the community health center with post-incarcerated patients. And Westside currently is doing a lot of outreach with the reentry population.
Just for clarification, the people who aren't familiar with Westside Family
yes.
Health Center, if you could.
So Westside Family Health Care is a federally qualified health center. We've got 6 sites throughout the state of Delaware, and we provide primary care services, everything from pediatric care to mental and behavioral health, including social work and dental. And anything that we do not do, we have healthcare coordinators that refer out to different specialists and frequently to Christiana, you know. So with that being said, so a part of something that Westside does since 2013, you know, with the ACA, we actually help to sign up for healthcare coverage. And we actually do something more broader than that. We actually not only sign them up, but we connect them back to a medical home. So something we've recently gotten into was working with the reentry population here in Delaware, and we are actually in the probation and parole offices every single week trying to connect, you know, consumers to healthcare, you know, whether that be actually commercial healthcare through the marketplace or Medicaid. And also, I've actually personally called our scheduling line to set people up for appointments to get them to see a doctor when they haven't seen one in 5 years. So I think all that to say that I think, you know, with funding being the obvious issue, this might be something that we could possibly replicate here in Delaware with the resources that, you know, there's 3 different federally qualified health centers in Delaware with not only Westside, but all of community organizations that we partner with. So question is, what or were the barriers to getting the TCN started? Like, I'll just leave it there.
Sure. So, you know, one thing I was going to say, and thank you for your comment and then question, is that a number of the community health centers that we've worked with are federally qualified health centers, and we've also thought about kind of that being a path by which to sustain this work, right? They get different reimbursement rates for taking care of vulnerable populations. People with histories of incarceration aren't one of those vulnerable populations, but we've been in conversations with Department of Health and Human Services and HRSA in particular, thinking about kind of, again, appropriations that might be specific to people with histories of incarceration that are returning home. One of the FQHCs that stands out, and when you said dental, I was like, this is great, is that in New Haven, our program splits between Yale Primary Care Center, which is the academic community health center, and then our Cornell Scott Hill Health Center. And at Cornell Scott, again, because of different payment structures, what they've enabled is that a person comes home from prison, you know, our community health worker takes them there, and then they can get a single visit with a provider, or, you know, the double triples, what they call it, which is a visit with a provider, a visit with a medical provider, a visit with a behavioral health provider, and their teeth taken care of in one visit. And so, again, our programs are situated in community health centers, and the community health centers then think about kind of what resources, what payment options are available to then be able to provide kind of patient-centered care for our patients. So to your questions about barriers, and then one other thing that your point brought up for me, which I think is as critical, is that I think it's amazing that you guys are outreaching in to probation and parole, and we often do try to keep a firm line, a distinction between, you know, people ask, like, why don't you just mandate primary care? And that's the least of our interests. You know, we're not looking to create another system of control through the health system. We're trying to engage people on their own terms into the health system. And so the things that we do are, I think getting people insured is important, but that's kind of that, it's a sufficient but not, you know, it's a necessary but not sufficient step to getting them engaged. And the key core, you know, like the secret sauce here is the community health worker. And so that gets the barrier, which is how do you pay for community health workers, right? So you can pay for providers' time. If you're in an expansion state, it's not a hugely high reimbursement rate, but you can pay for providers' time. But the community health workers' time often is the kind of most difficult part to pay for, and that is the secret sauce. And so, again, if there are health systems and health systems we've worked with that have accountable care, you know, organizations, and so can pool the money in a more population health manner and think about kind of how you prevent kind of more costly expenditures by investing in lower cost inputs like a community health worker, that I think is critical. So the payment to the community health worker and the supervision of community health workers is critical barriers. I think, you know, we've developed experience with how you think about this, but I think that there are, as Nicole was talking about last night, Alabama, a state that has not expanded Medicaid coverage for low-income adult males, is a particularly challenging place to start TCN. Delaware, however, it's not the case, right? So you have a health system that's invested, federally qualified health centers that are invested, and so then finding the funds within community health workers has been far less of a barrier.
That's wonderful. Just one comment before Dr. Medania will have the privilege of asking the last question. Stay tuned also. I mean, part of your statement was you think Delaware would be a great place to operationalize something like this. And I would say to those of you who are invested in our community, one of the reasons that we invited our speakers here today was obviously to inform you about the science and about what exists in terms of a national model, but also to stimulate thinking about how we might explore doing something very similar here in Delaware, okay? And so our intent is not to have this be a one-off half-day symposium, but instead an introduction to the topic and to begin more concretely exploring a model of care delivery here in Delaware. And certainly, if we're successful, we need organizations like Westside to be engaged. Last question.
Hi, thanks again for coming, you guys. I'm one of the trauma surgeons here, and we tried to implement the model of a community health worker here with the city, with us. It's kind of a conglomeration mishmash. No one's really taking ownership over it, but we all really respect the community health worker. And I think it's our responsibility as physicians and as a health system to give them the credit that they deserve, to show that your data on going back to prison and the emotional and physical support that they provide your patients is tremendous. But they don't get compensated, like you said. So one of my questions was, how do you pay them? Okay, so we'll figure that out later, I guess. But secondly, I think it's important that we keep advocating for them because, like Dr. Payne has said several times, we're going to become complicit in taking money away from the community and not giving back. And we really need to, as a level 1 trauma center, as a CCH health system, have to say, no, we can't do this work without the community health workers, which is the community. That's the first thing, and we need to get that funding so that the community can be engaged, because we can't do this without them, right? Second thing is, in Delaware, and probably in your communities as well, the community health workers need to be trusted by the patients. And so therefore, how do the community health workers navigate? I don't know if you can answer this, but how do they navigate that issue of HIPAA or privacy and being present for the patients and knowing really intimate things about those patients when they're going to be neighbors, or they're going to be living in the community with each other? That's an issue that we struggle with here, is that we want somebody to have someone they trust, but then that patient might not want to share that information with them, that either they got shot or they have money problems or whatever the case might be. So I was wondering if you could answer the logistic question about how do you handle privacy within the community.
So, I think that this is critical, is that this is a kind of, it's obviously different for providers here, than community health workers, because they do live in the community, but this is an issue of constant kind of workforce development, which is, all of our community health workers completed kind of a college, like the oldest college CHW program, and this is part of their continued training, is like knowing what HIPAA rules are, trying to respect the privacy of patients, trying to respect kind of, again, some of our community health workers serve time with our patients. They know them from way back, And so these are kind of critical issues that as a network we navigate together, but also have kind of a fine attention to what are strong and important health system regulations about protecting the privacy of patients.
I'll say real quickly, there are also now training programs specifically for community health workers and behavioral health as well. And these programs are starting to grow as this community health worker model starts to grow. So I think now there are actually more resources than even when TCC first started for training and ongoing training actually for community health workers.
And I wanted to reiterate a point we kind of discussed at dinner in terms of workforce development. So a lot of our discussion has been around the patient and the newly released type. But I think one of the most moving parts for me, and we discussed this last night, was, my community health worker who her history of incarceration was actually pretty remote, but she'd really struggled getting stable employment. She'd done master's in social work. It was in the middle of an online PhD program, hoping to improve her career prospects. And, I think settling on this program was so personally meaningful for her in terms of really being engaged. And I think that's something we all look for in our career development. We don't want a job, we want a career. And I think this really gave her a true kind of calling and where it could really use her entire experience, both personal and her professional training, to synergize. And so I think that's another kind of ask. One of the things that we struggle with this population is employment. Well, okay, this is an ideal setting to get people gainfully employed. If your health system employs them, then they have access to employer-based health insurance. Then this is one less person that we have to, kind of patch together. And so seeing this workforce development as a worthy investment in the long run in terms of all of these kind of, the personal development for people as well as the